from my side. And the background on which we are going to talk about this, because we all know that there has been a problem with obesity and hernias, and where we stand with regards to doing bariatrics. So, more than 60% of mental hernias are on patients who have a BMI of more than 30, according to the world literature. And of course, increased visceral fat is seen as one of the problems. Then abdominal wall circumference is the next one, and then we have elevated intra-abdominal pressure. Then we have higher chances of infection, and of course, the collagen metabolism also plays a role. So to get into a little bit of a detail about it, about the fat volume, they have very high significance than the BMI in obese patients. And waist circumference of more than 100 centimeters increases chance by 21% to form a parasternal hernia and 21% for an incision hernia as well. And in fat volume, if it is a skeletal fat volume increase, then the higher chance of recurrence with higher chance of infection as well. If there's a higher visceral fat volume, then there is a challenging facial closure, which increases the chances of incision hernia. So that's when the fat volume plays a role in hernia and obesity. And the intra-abdominal pressure, in an obese patient, the pressure baseline is about 8.8, which is against 0 to 6 millimeter mercury in a normal patient. And of course, there is an increase of 0.14 per BMI, and per age as well, 0.20 increase. So the more older you are, the more obese you are, you tend to have very high intra-abdominal pressure, leading to more recurrence and again complications as well. Higher chance of strangulation, obstruction, and incarceration as well if this IAB is higher as well. And of course, should be, if the pressure is more than 12 millimeter, it has to be considered as a pathological condition, has to be tackled very seriously. And the most important again is the collagen metabolic disorders. The collagen 1 and tryptophan 1 are the most commonest collagen proteinases, which are pretty low to cause a lot of problems if you try to repair these patients. A perfect repair still can be a bad repair when it comes to obesity. There's collagen 1 and MMP1. MMP1 comes down by almost 60 to 65%, from 64 to 28 around in obese patients. And again, collagen 1 from 1.6 to comes to 0.2. So it will be 50% reduction of collagen 1 and MM1 of about 60-70% reduction. And this is very, very important for a recurrence in a hernia in the patient with obese as well. So now, surgical infection, again, because of all these issues and morbid obesity, we all know SSI is pretty common. BMI of more than 35, we have a very higher chances of SSI, and it's more common in femoral umbilical hernia as well. And BMI of more than 30, a twofold increase in the risk of developing an incision hernia because of SSI coming along with it, and of course, significant contribution to incision hernias. Now the dilemma what we have with all this pathology in mind is, with a wide range of presentation in obesity, what we are going to do with it. And of course, there is an initial finding of 21% if the BMI is 35 and above. You go for any other surgery, 21% chance of a hernia in an obese patient, the BMI is more than 35. So most likely we'll have an incidental finding of hernia when you're trying to do a bariatric surgery or examine the patient for bariatrics. And of course, it's can be also concomitant presentation along with obesity when the patient presents you as well. Then the question is, okay, what kind of a hernia repair I should be doing for this patient? If metabolic surgery or surgery is considered, what is the ideal type of hernia? If it differs, the kind of hernia differs, or if the patient is admitting for surgery, how to go about? These are all the dilemmas we're going to have. When we talk about hernia surgery in an abdominal wall, hernias, reconstructions. So, obesity, we all know, is an absolute risk factor, and operative risk increases with the increase in the BMI. From 5.7% in normal weight patients to 19.9% increase if the patient is super obese. That's a pretty very high chance of having an increased chance of recurrence or any other complications. Then, when it comes to whether we do a open surgery or a laparoscopic surgery, it's a no-brainer. Of course, we all try to prefer a laparoscopic surgery or open surgery. But there are situations like, okay, when the tissue handling is low, we all know that the recurrences and complications are low. And if the necessity is one of the major factors of recurrences of hernias, better we try to go with the flap surgery wherever possible. And complication rates are as high as 75% if the BMI goes beyond 40. And in multiple presentations, then have a difficulty whether to go with lap or we have to do open surgery. But as per literature, a laparoscopic hernia repair in obese patients has very good results of 94.5% success rate. And when it comes to loss of domain, yes, we make them do an open surgery, and that is when we have to decide when to do an open hernia in a morbidly obese patient, and whether we do paniclectomy along with it is necessary or has postponed. That's a question again. And of course, risk of general anesthesia is there as well when doing bariatrics and hernia together, and then the mobility of the patients can be a challenge as well. Then, when we talk about the choice of surgery, as per literature, IPOM or IPOM plus is the most preferred choice in a morbidly obese or super obese patients. Most recommended technique as per the literature is available, and of course, because non-creation of a dead space, so infection chances are much lesser, and then there is operating time is much more smaller than any other hernia repairs. Then there are a lot of surgeons who do anatomical repair in a concomitant surgery. But the problem with it is there's a very high chance of recurrence of up to 52% in these patients, and these are commonly considered in concomitant surgeries, and especially when they have strangulation or obstruction hernias, when they want to take more time in a hernia reduction and repair, that is when they do the anatomical repair. Then the compound separation or restopa or heater. So any other forms you want to do, most likely these are all delayed surgeries after the patient weight loss. So long-term benefits are to be seen here, so that when these surgeries are more delayed, and of course, as always, it's a second stage procedure, these are much better as per the literature. So when we talk about the hernias in the morbidly obese, we talk about two important things. One is what is the symptomatology, whether it's a complicated or uncomplicated, or whether it's a favorable condition or an unfavorable condition. So we did some research in about 50-60 odd presentation in our publications, and we had our own chapter written on this. So the symptomatically uncomplicated are rare history of nausea, chronic constipation, vague chronic pain, and reduced bleeding. And so symptomatic history of abdominal pain, features of partial or complete obstruction, previous history of hospitalization, and of course a recurrent uncontrolled hernias. Then the favorable hernias are called less than 8 centimeter hernia size, single hernia, BMI of less than 40, and then reduced bleeding. And of course, more than 40, BMI, 8 centimeter above, android pelvis are very common, called unfavorable. So based on this, the decision can be made with the type of choices. So now, when it comes to bariatric surgery, what are the choices we have? Whether we want to do hernia first, when we do the bariatric first, or concomitant. So literature-wise, plenty of literature has come up saying concomitant is pretty good, but then when it comes to hernia first, when you have symptomatic patient with a large hernia, when the patient comes to you with a hernia with a symptom, we all know that the pathology when the patient comes has to be tackled first. If the patient is not willing, or the patient is symptomatic with obstruction or something like that, we may have to tackle hernia first, make sure that patient is all right without much complications, and then we can go for surgery later. But again, the literature is coming down and down on hernia first most of the times. And asymptomatic hernia, less than 8 millimeter, is of great concern on this. And then concomitant metabolic surgery or bariatric surgery along with hernia repair. The most recommended of all, if the patient is uncomplicated and favorable condition, then it's a no-brainer, we go with it. And of course, they have a reduced complication rates, recurrence rates, especially when we do a IPOM plus with this patient and not go to the ETAP or RS component separation for these patients. And bariatric surgery first, followed by anti-wall reconstruction. Again, an uncomplicated patient, but the patient is unfavorable. The patient has multiple harbors and things like that. And of course, there is a always debate about no repair or anatomical repair or just try to work towards concomitant if possible. So when we talk about MBS first, there are some surgeons who do anatomical repair to make sure that the patient doesn't have an obstruction of the interior. But most of the times, this comes into triangulation. So that when there is a good neck available, just leave it alone and always come back later for repair. And so comes to surgery. Hernia first, symptomatic hernias, previous episode of esophageal obstruction, carries high risk of recurrence and may require additional paniculotomy later. This kind of conditions where hernia can be done and then paniculotomy can be done later and then bariatric surgery can be added. Bariatric surgery first or a concomitant surgery where asymptomatic hernia, small size hernias, when it reduces the recurrence rate very clearly and best cosmetic results you want it, and then carries risk of developing a hernia complication in these cases if you try not to do a proper job. When it comes to reinforcement, again there are a lot of doubts we have whether to suture closure, biological mesh or a synthetic mesh. When it comes to suture, the recurrence rate is pretty high, 24% chances if you use sutures, and then complications can go high as well. So wherever possible, try to avoid, especially in very small hernias, umbilical hernias, we can do suture closure, but otherwise leave them alone or concomitant repair is recommended. Biological mesh recurrence is 14% because these patients, once the biological mesh disintegrates, chances of hernias move. Because still the IAP and SSI and collagen pathways are still working bad for these patients. Synthetic mesh has the least of 1.1% recurrence if done in a concomitant situation. So wherever possible, you have to use synthetic mesh. Wherever possible, try to have a favorable condition to work on a concomitant. Otherwise, surgery first, then hernia later is only in case where we need a component separation or restore or big repairs. That is when we need to do a hernia first, or MB first situation and then hernia later. So this is a typical hernia where we did a closure, concomitant surgery. But again, in our concomitant surgery, we always do a double A. One, we completely close the defect anatomically and then put the mesh over it. So we have double protection and we have very good results with this concomitant surgeries, even when there are multiple powers and the abdominal wall hernias. Then post-operative infection is one issue what we have. We do a hernia first. They did a lot of culture reports. There were no growth or 5% culture without any mesh infection if you do a hernia first. Concomitant metabolic and AWRs. If they do a sleeve gastrectomy, still it holds true like a hernia first surgery where there is no growth or up to 5% growth with no mesh infection. If you do RVGB or one anastomotic gastric bypass, between 5 and 10% culture, but again there is not much of infection when they did a culture. So again, the culture grown are mainly staph and streptococcus and not any intestinal pathogens. So that is why concomitant is pretty much recommended wherever possible. Of course, inflamed bispillage or underprepared bowel and a lot of bowel fluids are causing a lot of chemical peritonitis. In that case, we have to avoid. And especially IPOM or IPOM plus may be beneficial in those cases because we are not getting any dead spaces. Otherwise, we may have to abandon the hernia and do later, or if it's a complex situation, standard situation, do the hernia first and then bariatric surgery later. Our series of around 163 patients, around 1,800, so 99% incidence of obesity and 48% in incident finding and 23% symptomatic presentation. Then we did another study on about 163 patients, where concomitant surgery of optical hernia, ventral incision, gastric hernia were done. Then bariatric first in 19 cases, and then hernia first in 3 cases we did. And then when we tried to work on complications, there was 2 cases where we had complications in a sutured hernia where there was strangulation, and in recurrence in 4 patients, and it happened in an umbilical hernia. It became a recurrent sutured one. We have one in biological, we had 1 recurrence, and in synthetic we had 1 recurrence. There's a total of 6 cases, so 3.8 recurrence. So 1 case has to be immediately operated with strangulation, where we did a suture closure, just we took it off later because of the recurrence. things, the algorithm, what I would like to propose is the vertebral hernia and obesity is symptomatic, uncomplicated, IPOM and bariatric surgery together. It's complicated, IPOM with conference operation or AR if the patient is pretty much favorable, or you do bariatric surgery and then do the rest of things later. If patient is asymptomatic, if it is favorable, then bariatric surgery with IPOM. If it's unfavorable, bariatric surgery plus or minus IPOM if possible. Otherwise, it's not possible. If you have to be a conference operation or abdominal reconstruction, do them later and do bariatric first will be the recommendation. So, to summarize everything, obesity is associated with so much of elevated complications and recurrences both in primary and institutional hernias. Absolute risk factor of complications recurrence are very high, and treating only obesity and hernia can lead to higher recurrence and complications. Concomitant bariatric surgery and hernia is recommended wherever possible. Laparoscopic IPOM is the most preferred procedure, and open technique often have more advantages in treating hernias in the loss of domain. So that is the case where we do a bariatric first followed by hernia. And then timing and technique of bariatric and hernia surgery should always be tailor-made depending upon the presentation, and type of bariatric surgery does not alter the hernia repair technique. Thank you.